This is Lori Jones. Thank you all for joining to learn about our recent survey findings to see what keeps healthcare finance executives up at night and what they plan to do about it. For those of you who don't know Conance is the leading provider of predictive analytics solutions that personalizes the financial and clinical experience for patients to improve net incomes, patient outcomes. Conance Solutions also connect more than 500 hospitals, over 1,000 physician practices, and more than 80 collection agencies nationwide. During this webinar, all attendees will be on listen-only mode, and if you have any questions, please type them into the question bar on your control panel, and they'll be answered during the webinar. Now, I'd like to introduce our host for the session today, Steve Levin. Steve is our CEO of Conance. Steve?
Good afternoon, everybody. I'm looking at my picture on the screen here, and I've decided that we need a new picture. My ears are too big. Welcome, Laurie. Do you want to do the quick disclaimer? So before
before we get started, the following information is not intended as legal advice. It may not be used as legal advice. Legal advice must be tailored to the specific facts and circumstance of each case or inquiry. Every effort has been made to assure that the information contained in this presentation is up to date and as of the date of this publication. It's not intended to be used for a full and exhaustive explanation of the law in any area, nor should it be used to replace the advice of your own legal counsel. Now that we have that out of the way, Steve, we can get started.
I'm on. All right. Thanks, everybody. For those in the East time zone, good afternoon. For those of the rest of you, good morning. Hopefully, I'm looking at the list. I don't know if we have what our split is between Cubby and Indians fans. Best of luck to all of you. Being a Red Sox fan, I couldn't care less. Thanks for joining. Today is sort of a kind of a retrospective on some work that we had done here at Conance over the last summer. We did some survey work and an opportunity to share it with folks. Unlike some of the other things that other webinars we've done, which tend to be more solution-based, this discussion is going to be much more about kind of state of the kind of what we're seeing in the market or what the market's telling us. We have a 3 or 4 part agenda and Q&A. If questions come in along the way, we'll take them. Otherwise, we'll leave time at the end for them. The goal here is probably give folks a little bit of time to eat their lunch at the end of this, so assume 35, 45 minutes, something like that. So let's start with kind of what I think we all know about the hospital, in financial context, which framed sort of the kind of questions we went out to the market with. Then we'll go through kind of the survey, who we actually talked to, what we asked them, and then sort of what they said to us. And we're gonna kind of tease you all with a little bit of other work we've done recently on some consumer stuff, which will kind of bring this all to a close. So with that, I'm gonna kind of hop into the context. And have I looked at a little bit at the attendees and knowing some of you, I think a lot of the context you probably all know well, but it's always good to ground ourselves. If we go back into 2010, 2011, 2012, the grand government EHR meaningful use giveaway, there was a race for the cash, but that's sort of that race seems to be by all accounts behind us. If you look at the penetration of electronic health records, certified, the various point of view, whether it's from HIMSS or the government reporting, et cetera, shows that we're getting to the point where almost everybody in the market has an electronic health record, that we have physicians are now rolling onto these, and so the EHR deployment, the challenges of getting these things in place and up and running seems to be sort of behind us. Now, that's not to say there aren't still a number of people who are putting in Epic or putting in Cerner or upgrading to the next version of Epic or upgrading to the next version of Cerner, but the sort of the out of the blocks first dash to kind of the kind of meaningful use and some of that stuff sort of is in our rearview mirror. And I think the reason that's important is because it means that now people are starting to ask questions about optimization and performance. One of the things that we've heard a lot, and I think you all heard too as well, is when you put in a new patient, a new EHR, or patient accounting system, they actually don't come out optimized, they come out stabilized. And so when you talk about, Epic out of the blocks, everyone who puts in Epic talks about, I really want just to get my AR under control, I want to get my business office under control, I want to know where everything is, I don't want to be losing records. And so that stabilization period is different than optimization and actually performance management. And the fact that EHR, kind of the rollout sort of behind us, means that we can start thinking about optimization and start thinking about performance again. Now, when you think about that, there are some broad trends that everybody on this phone appreciates. First is we've got a very significant shift in payer mix. We've got a declining percentage of commercial, shown on the left here, going from the almost 40% to below 40%, 3 or 4 or 5 point decline is sort of what's projected between 2014 and the years ahead. The reason that is so important is because shown on the right, which is the kind of the value of every dollar of that payer revenue. And effectively, I think we all know, is Medicaid, Medicare basically reimburse at well below the kind of the cost of care. Whether we can argue about whether it's 10%, 20%, or 30%, but effectively the fully loaded cost of care is less than the government reimburses. And so if we're going to actually have a viable health system, we need private payer money, shown here in the yellow line. Private payer is the fuel that creates the shortfall, if you will. And so if as you think about what's happening, the projections around the declining percentage of revenue from commercial payers, that means an increasing share of revenue from government sources. That's going to create real margin pressure. And I think we all know that the reimbursement, the increases in healthcare reimbursement rates are slowing. The other thing that's happening is, and this chart sort of, it's straight from Kaiser, and it sort of is like a psychedelic, one of those old psychedelic posters we grew up with. But it has, because of all the numbers, but effectively what it shows is that not only are we seeing declining kind of role of commercial payers and increasing government role, we're also seeing a fundamental change in the type of plans that are in the market. And if you look at the bottom here in 2016, 29% of enrollees in kind of employer-sponsored, so non-government plans, are in high-deductible health plans. 29% in 2016. It was 10 years earlier, it was 4%. Now, what is stealing share from? It's stealing share from POS. It's stealing share from HMO. It's conventional, which is sort of the thing that our federal employees get, as our senators get, which is kind of the all-paid Cadillac programs, are basically dead. So we're seeing that literally it's the fastest growing plan in the employer side are these high deductible health plans. We also know that if you look at the government exchange, the majority of plans issued are bronze or silver. Those have 30% plus consumer contributions in them. Those are actually pure and simply high deductible health plan designs. There's no question that not only are we seeing declining commercial kind of as a payer, we're also seeing increasing high deductible forms. Now, what does that mean for all of us on the phone? We all know this, but it means that we're seeing a huge portion of our revenue now coming from consumers. Patients, consumers, you and me. Shown here is the average kind of deductible for single coverage by plan type. Again, I find this chart just stunning in terms of the relentless, trajectory of these numbers. I don't know why the first one says 2016. It's actually 2006. But regardless, from 2006, the lowest increase change in these numbers is actually the high deductible health plan, which is only up about 20% over that period, but it's 20% from a $1,700 deductible. If you look down at the point of service, POS, that's actually gone from slightly over $500 to almost $1,700, literally a tripling in the 10 years. So we're seeing, declining government reimbursements. We're seeing increasing patient, increasing role of high medical plans, and patients are facing massive amounts of the kind of financial responsibility. The third broad trend that is in our marketplace today is kind of this kind of frequently talked about, transition from fee for service to risk, and what risk means and how it's calculated and the various forms it comes in is probably a webinar or two in its own. But a simple way of looking at it is, let's talk about is bundled payments, for example, which is where the provider is being paid not only for not the individual service, but for the package of services that solve the whole condition. So, joint and hip replacements, a baby bundle, like everything for a woman in a family around the baby, the prenatal, the delivery, then the period after. So HHS and Medicare have set very clear standards. They came out in 2015 saying we want 50% of our payments to be kind of risk-based by 2018. They set 30% by 2016. They declared victory on that just this year. They are moving very rapidly towards risk-based reimbursements where providers are going to be paid based upon the extent to which patients do what they're supposed to do, and the overall kind of series of clinical encounters comes out with a solid, high-value outcome. So, the various pieces here, and I don't want to belabor the context because everybody here sort of has spent time in this in other places, but it led us here at Conant to start questioning the kind of what's going on, what are the priorities that finance executives, CFOs, VPs of revenue cycle in that level are looking at as it relates to their financial context. Because the EHR bubble is sort of behind them. We can have a long conversation about the ROI of that, but it is behind them. Now we have this focus on what's going to be, how do we optimize performance of that. We've got a shift in our payers. We've got a shift in our plan design. We have a world coming where the patient is really going to be front and center. So we went out and talked to a bunch of executives. We talked to not an easy group to get to, I will confess. We went and asked about 93 senior hospital executives. To qualify, you basically had to be a CFO, VP, or SVP of revenue cycle, or a revenue cycle manager where you had a budget authority. So you really had to control where money was spent. We did this over the summer in the 16th, so in July, and we used a third party. We didn't want it to be come out as Conant's, so we used a company called Porter Research to execute this. And so Porter reached out to these people. You can see that the majority of respondents were CFOs. We also were able to map back through Porter the respondents to facility size. Interestingly enough, just under half or so were in sort of standalone or individual operations, or up slightly under 150 million of net patient revenue. But we do have a share of them that come from networks, where you talk about over 750 million in net patient revenue, whether networks or large single site facilities. And so it's a cross section actually that's not too dissimilar from the U.S. portfolio. And so it's not a bad sort of sample, if you will. We asked for those on the phone on the webinar who may have gone through the survey, this will be all familiar for the rest of you. We asked folks a long list of initiatives, and we were sort of incredibly precise in what we asked them in terms of the various initiatives. We asked them more than 40 different initiatives that we said, on this list of 40, tell us which ones basically are strategic initiatives for you, like number ones. And you could pick none, you could pick all 40. And the themes were around cost control, patient engagement, denials and underpayments, insourcing, vendor management. Those are sort of the broad themes. But we basically said, look, of this group, and we offered it to the survey respondents in kind of bundles. So of the following 8, please tell us which ones are number 1, strategic initiatives for your enterprise. So they identified all the ones of the 40 plus that were number 1s. And then we said, okay, for only the ones that you've said are number 1s, we want you to order them in terms of what's the most important to you. So if you selected 5 of the 40, we wanted to know what the order of the 5 was. So which one was number 1, which one was number 2, which was number 3. Recognizing they're all top initiatives. We just want to know what the relative order was. And then we asked them to talk about how well they did, what they thought the type of opportunity there was for them, and how they were looking to accomplish it. And so basically we're saying, look, if this is your most important, are you terrible today, and you think you're going to need huge consulting endeavor to get there, and we could be great. And we framed all of this as kind of what are you spending, or where are you focused on the next 1 to 3 years. So it wasn't next week, it was 1 to 3 years. So let's start with some of the early kind of interesting sort of pivots, insights, which was the following. When given a list of 40 plus, people literally selected, we had people selecting as many as 25 key initiatives. We had some folks focusing on less than 4. The average was about 14 or 15. That is really a jam-packed agenda. Some of the initiatives are similar, but people were really, they could have picked the bigger points and ignored the little ones, could pick the little ones, ignore the big ones. People literally picked, 14 or 15 out of this list and said, these are our priorities. This is what we're really working against. That is a very full agenda. And I think it speaks to what we probably all know and feel, which is there are a lot of balls in the air if you're a finance executive today. Okay, so what were the tops? So 81% of the folks identified preventing denials and underpayments as their number 1 initiative. So these are the ones, this is after they've pulled these all out and said, these are my top, so these are the initiatives that have been said, these are number 1s, and then within the number 1s, they've sorted them in this order. And 81% of the time, preventing denials and underpayments was a top 10 priority initiative. If you can see the list there, so preventing denials, lowering cost, resolving denials, which is different than preventing them, collecting patient balances at point of service, increasing my collection rate among people with balance after insurance. And I think that's much more about what am I going to do when they get back to the business, the back end, no longer a point of service. Calculating patient liability, a very precise question. Within lowering total cost, lowering my patient balance cost. Of the list, what we found is 2 of the top 3 initiatives were denial related, commercial claim denial management. 4 of the top 10 are related to the patients, right? There is clear evidence that people are saying, I'm not so worried about the government stuff. I want to get every dollar I can from my commercial payer, and I need to figure out a way to engage my patients in a different way. When you ask what was most frequently the number 1, what was literally the one, calculating patient liability prior to or at point of service was number 1. 17% ranked it as their very first. 4% ranked it number 2. Developing a comprehensive patient liability strategy, 12% ranked it their very first priority. 3% ranked it number 2. 10% ranked preventing denial and underpayments as the first priority. 16% ranked number 2. And that's sort of, you can see if you take 10 and 16, that gets you to 28. That's sort of how preventing denial and underpayments rises to sort of the premium in the prior page. But these are the 3 things that the industry executives are focused on. Engage these patients, get them to pay their bills, and then get paid fully and fairly by my commercial payers. Question of larger versus smaller. We were able to split the ranks. We basically kind of draw a line around 200 million in net patient revenue. Instead, if you're over that, you're kind of the larger side. If you're under that, you're on the smaller side. There are some differences. There are some similarities in the chart. You can see everybody, in terms of what % ranked preventing denial and underpayments as number 1. Everybody, whether you're large or small, made that that was the most frequent top 10 kind of election, if you will, top strategic election. Lowering cost to collect was a bigger deal for large systems than small systems. Small systems were more focused on resolving denial and underpayments, getting the money, getting the cash in. You can see that collection rate among insured patients sort of bounces down a bit. Small systems focus on collecting more at point of service. The kind of pink ones are the unique ones. And I think number 4 is interesting. Larger systems are much more focused on this challenge of bundle payments and how they're going to deal with them. I think that's probably a reflection of the fact that the larger systems in the country are the ones more rapidly moving into kind of bundles and risk-based reimbursements. A lot of individual kind of small hospitals are moving in more slowly. They're not kind of proactively pursuing it. Maybe the commercial payers don't have it as fast. But when you get to these large urban centers or larger kind of networks, bundle payments and it's shared both to commercial and government is increasing. It's becoming a larger issue. What's also interesting is larger systems seem to be more concerned and more focused on financial assistance and some of the charity kind of elements, presumptive charity pieces. With the smaller ones, by and large, tend to focus much more about cash, and more cash. Again, an interesting kind of split. I think it reflects the different contexts of these people. Okay, so let's talk about current performance and how we're doing. We didn't ask, the way the survey asked, and we asked people to tell us if they thought their current performance for one of these initiatives was poor, fair, good, or excellent. If this is a top initiative, as you'd expect, you don't get a lot of excellence. Most people would say for these initiatives, 60 to 75% would say that they were poor or fair. The exception is this question around collecting from balance after patients. I think there's a sense that people feel like that, especially in the back end, that they're okay in that dimension, although it's still a top priority. If you look at some of the kind of the ones identified as interesting from the group, 68% said that preventing denial and underpayments, they basically said they're poor or fair. So the prevention efforts are sort of lacking. I think 67%, which was a close second, would say that their ability to lower cost to collect was poor or fair. The weakest was point of service collections as a key initiative. So if you want to know which was the one that has the highest number, it's taking the red and yellow together. It is collecting more POS. Again, the people who are putting the initiatives up top would say that they don't do a very good job of it today. So how are they going to close the gap? Again, it's a survey. We only get so many questions to ask them. It's a part to drill in. we basically said, look, they're make no change would imply we think we've got it under control. We're basically going to execute. We're going to get some consultants to come in and help us. We're bringing some new technology. Or adding people. And the kind of the trends here are the following. One is consultants are not the solution in the market at the moment. I don't know if there are consultants on the webinar, but the market is saying, we really don't want to have somebody else fix this. We want to get either our people to do it or technology to do it, and so that's our preferred path forward. For the people that are trying to work on the denial underpayments, they're majority of them looking at technology. They're looking for new technology. People that are looking at calculating a point of service are looking at using new technology, and you can that's the big blue bars shown. Similarly, analyzing denial underpayment to find patterns, that is a big blue bar. 40% of the folks trying to lower the cost to collect are basically trying to do this through their current team, their current technology. So if we're trying to kind of lower the cost, the way they're trying to do it is sort of through kind of their team, work smarter, be more productive, et cetera, but they don't see technology as their answer, if you will. Okay. Again, it's not an exhaustive survey. I think there's some interesting things in here which we would kind of point to as we look at the agenda, as we look at what people said to us. The first is, and this is sort of a related survey that we did recently, which is about patients, because patient engagement, patient satisfaction is interesting. It sort of goes with this question of where hospitals are trying to engage patients, pay more money. The question is, how well are we doing? And we do a survey annually or thereabouts where we ask patients their satisfaction with the business office and billing process from their last hospital visit. Done this for a couple of years. The one we just did, I'm not sure if this data is out yet, but basically about 33% of them gave their last business office a score of 5 on a 1 to 5 score, which was sort of the fully satisfied box. Continue to see that about 50% or so rank 3 or less. Not 3 being a non-distinctive solution experience, 1 and 2 clearly being dissatisfied. What is interesting about this year's survey was that we've run the survey now going back to 2010. We actually didn't run it in 2015. Apologies to all that are desperate for that data that number. But when we've run this in 2010, you can see the yellow score, the scoring of 5 was under 20%, and it has risen to this kind of 32, 33%. But it rose there in 2014 and then went sideways to 2016. We similarly saw the folks that giving a 3 or less. It peaked in the 2010, 2011 time frame of 60, 65%, and it's fallen towards 50 in 2014, but then yet again went sideways. And so it's interesting in the survey data here, which mirrors the imperative that CFOs and financial executives are telling us, is we haven't broken the back or changed the consumer experience paradigm in the last couple of years. We've gotten better, but we really have not transformed it in the last bit. We have work to do. These lines are leveling off. And related to that was something that was interesting. In the consumer survey, we asked people about their balance due and their engagement, their response to the higher balance. And so the chart on the left shows, based on balance, did they feel the need to call into the business office and ask for help? Blue and red basically say either I have or I will. Green means no, I didn't need to. And so what you can see here is that on the left chart, when the balances go up, there's an explicit need to engage. And what they do, so higher balances is driving engagement, and which means it's driving cost, actually. What's also interesting is the one on the right, because we asked people in this survey this year, kind of if the balance they had to pay was more than they expected, what they expected, or had they didn't expect to pay anything, so whether it wasn't a relevant question. And what you realize is that even the people that had high deductible health plans, the size of these balances were significantly larger than they expected. And when it was larger than they expected, they always called in. So you got this expectation driving costs and driving engagement. So if we try and connect those kind of the initiatives that we're seeing CFOs and VPs of Revenue talk about, it sort of matches up to what consumers and the market trend is saying, right? We are seeing a dramatic change in the reimbursement architecture and the risks of around that, and margin and new payers. And so we've got a very, very long list of to-dos. We have CFOs and teams working 14, 15, 16 different initiatives as tier ones. And the market is and the market's saying, yes, you need to work on these. You need to get after this stuff. As a finance person who, as somebody who has his own to-do list, I think this opens up a question of how clear are our objectives, how much conviction over time do we have, kind of the ability to stay true to it, work over time, and do we have the right partners? I think when you think about 15 initiatives that are mission critical, when you think you have to bring in technology, when you think you have to kind of really change the experience, because that's what people are telling us, we all know we're going to have to get the right team together. And so how do we have the right team? Who's on that team? And you sort of we don't want to be like the cartoon on the right, which is sort of flying around in circles all day and not make any progress. We've got to break the back of this, which in a way that lowers our costs, engages these patients in the right way, and gets us paid, whether it's from the patient or the commercial, or the government or the commercial payer, fully and fairly. So again, I don't want to kind of overstay my welcome. That's we're 35 or so minutes in. Are there questions that people have on this and on the survey or some of the other stuff? I'm happy to answer. And I think the survey is available on the website or through kind of an email to ROI.
That's correct, Steve. And Steve, there are a couple questions that have come in. And again, if you have any questions, feel free to type them in on the control panel. The first question, Steve, is based on your experience with hospital systems nationwide, what is the most important first step to take in regarding with regard to preventing denials and underpayments?
Yeah, so I wish there was an easy answer to this, and you use the word preventing because I think it's an important word. So it is hard to do much until you kind of can see the problem, and so one of the first things is you do need to have a little bit of visibility to it, and so some reporting, some trending insight on it. So how many denials am I getting from what payer of what type? That reporting exercise is not as easy as we'd all like, having spent thousands, hundreds of millions of dollars on Epic or Meditech, whatever it is. Generally speaking, the reporting architecture in those systems is not very good. And the other piece of this puzzle is payers have a great way of making their reason codes and denials unique from one another. So, the same code, Cigna and Aetna don't mean the same thing with the same reason code. So there is a little bit of getting visibility to it. But visibility, in our experience and what we've seen around the country, visibility is not really sufficient. That the kind of breaking the back of finding the patterns, understanding what's really going on, requires some level of analytics and some level of workflow restructuring. I'm avoiding the word predictive analytics. That would be like pandering to the audience a little bit, I think. But this is, in our experience, you do need to use technology which has sort of got some pattern-based insight to it, because it is really hard, if not impossible, to create 3 or 4 variable pivot tables, identify identify a kind of a bucket of denials, trends, go off and fix it, and believe that that's going to go away. Because what's happening is we're sort of like, we plug one leak and then the payers change the game and a new leak springs. And so it's a constant game of cat and mouse. And so the only way to beat that ultimately is to have the computer do some work for us. So there's a level of sort of visibility, but there's really a level of computer kind of technology. I will say that what we've seen, if you kind of in the world of bang for the buck in this space, that there's a real upside in things like real-time claim statusing, and eliminating sort of very wasted billing follow-up activity. A lot of folks, the way they deal with denial of underpayments is on things like, anything that gets sent to the payers hasn't been paid inside 21 days. We're going to go look at the website and see where the claim is and see what the status is. Well, there is, many of the time, much of the time, that kind of what you find at the payer website is, oh, it's going to be paid tomorrow, or no, there's no issue, it just hasn't been looked at yet, or and sometimes you find out the issue, and then you have to kind of go out and you can try and fix it. There is technology out there which can really kind of avoid the kind of the waste in that exercise. It can go out, it can ping the websites, it can scrub on a claim-by-claim basis for detailed information, very, very specific information about where the claim is, what the situation is, so that if there's no issue, no high-cost billing resource who have too many alligators chasing them already, so no high-cost resource really has to have an unproductive, touch, if you will. That's got a very high kind of bang for the buck we're finding. And again, if you can eliminate 20, 30, 40% of the statusing work, those people can now dig into, the denials, the underpayments that they are facing, to kind of, get after that stuff better.
Great, thank you, Steve. I see that you you picked up the follow-up question there.
That's how I play.
Well, thank you, Steve, and thank all of you for attending our webinar and for your interest. If there's further interest in the survey or more about Conants, feel free to contact us at info@conants.com or roi@conants.com. Again, we thank you for your time and attention, and have a great day.